Okay, next will be a very important session for us patient again about quality of life. Joyce, Masha.
Yes, we are continue our sessions, and we are very happy that we are now talking about something different, but also important, very important, the quality of life of Sjögren patients. And we have noticed that there were a lot of a lot of questions about it, and it's in a lot of Sjögren patients organization. It's mentioned as that what is my quality of life, and what are the parts of it. And there are we have mentioned here in now several parts of this, and we are very I'm very grateful that we can have now Linda Kwakkenbos, also from the Netherlands, and she is a professor of the assistant professor of the University of Nijmegen, the Radboud. And she was told something about mental health.
Yes, thank you. Thank you for the very nice introduction, and also for having me and for all the insights that I have gathered already on Sjögren's. Because as you can see here on the bottom line under my name, my work mainly focused around scleroderma, which is another rare autoimmune disease, which some of you may know. But I think that, like Soren said, some of the general principles that we use in psychology in chronic diseases, especially chronic rare diseases, can be transferred to other diseases such as Sjögren's. So I'm learning a lot, but I hope that I can also give you some insight in mental health and psychology. I'm a psychologist by training and a behavioral researcher, and I was very happy to find Soren because he is in the same boat with me in that respect. And I'm going to speak about mental health in a positive way, and a little bit about mental health issues. And just a disclaimer, in addition to telling you about mental health, I also have a small exercise, because I know that about 5% of what I will tell you, you will remember after this presentation, but about 75 to 90% of what you experience, you will be remembering after this presentation. So be aware, there's no test, but it's a small exercise that I will walk you through. I do not have any disclosures. When you walk into the doctor's office, or as a doctor, clinician, when the patient walks into your office, what do you see? Do you see a patient, a Sjögren patient, or do you see a person who has Sjögren's, but also has a lot of other things in addition to this biological challenge? It's also a person with psychological challenges, but also psychological health, social challenges and health, who lives in a certain context. I see that the corners of the colors is not really visible, but these are like little circles that all constitute the person with a certain disease. The biopsychosocial model of health and holistic healthcare, and I think they go hand in hand. And if you look at Eurodis, they also made a priority of holistic care and holistic healthcare. And you may be surprised that when I'm at EULAR or at ACR or another rheumatology conference, that I'm one of the few psychologists actually who is present there. Whereas for you as organizations, this is such an important topic. Not to say that all of the medical research and advances are not important, but this is another important part of healthcare for people with Sjögren. So when thinking about health and mental health, how would you actually define health? And I'm giving you a moment to think about it yourself. If you think about health, what is health to you? Anyone who would like to share? What does health mean?
That I can do what I want.
Yeah, that you can do what you want. Yeah, thank you. Same for you? Yeah? Yeah. A good quality of life. Yeah, nice. From morning till night, wow. Yeah, thank you. Thanks for sharing that. Yeah, and actually for the longest period of time, the healthcare system has been focusing on the medical model of health until approximately 1977. The medical model of health, where health was the absence of disease. So that means that when you have a disease, or when you have Sjögren's, for instance, you will never be healthy again. I tend to disagree, and luckily many with us, because there's also something called positive health. And Machteld Huber, also from the Netherlands, by the way, she came up with another definition of health. And she said, health is the ability to adapt and to self-manage in the face of social, physical, and emotional challenges. And I'm teaching my third-year psychology students this, because they still, while we all talk about like the biopsychosocial model, they still have this like internal idea, like if someone is ill, you cannot be healthy. Right? But there's many things of positive health, adaptation, and self-management that you could still build. And some of this is related to the concept of resilience. And resilience basically is defined as the process and outcome of successfully adapting to difficult or challenging life experiences, such as getting a diagnosis with Sjögren, especially through mental, emotional, and behavioral flexibility and adjustment to external and internal demands. Wow, that's quite a mouthful. But what basically the idea is that you can build resilience. Like we all have a certain level of resilience already based on our life challenges that we've already had, our youth, our personality traits, etc. But you can also cultivate and practice resilience, improving your mental health or cultivating your mental health. And I think this is a really important component of what I would like to discuss today in this presentation. So I've given you a definition of resilience, I've given you a definition of health, but what actually is mental health? And often if we talk about mental health, we think about challenges, mental health issues, depression, anxiety, etc. But it's much broader, it's a much broader concept. Looking again, not at the disease side of it, but at the health side of it. So mental health is the capacity of every individual to feel, think, and act in ways that enhance their ability to enjoy life and deal with challenges. So again, very positively connotated, positive sense of emotional and spiritual well-being in someone's context. So thinking about this a little bit more, you could come up with this kind of like, it's like traffic light colors, I don't know if you can see it, but like the green on top, mental health. You have the capacity to think, feel, and act in ways that enhance your ability to enjoy life, deal with your challenges, and it doesn't mean that there are no challenges. It basically means that you suffer your losses and you pull yourself back up again. So that is mental health. On the complete below spectrum is mental illness, depression, anxiety, conditions that really affect your thinking, feeling, your mood, and behavior. And then somewhere in between is where I would think many people with a chronic disorder sometimes are situated, the mental health issues. It's not what we call in psychology psychopathology. It's not mental health, mental illness, but you have diminished capacities that interfere with your enjoyment of life and that interfere with your ability to rebound or recover from losses or challenges. So that's the orange part of this traffic light. Still with me? Yeah, good. Just to check. And then if you think about psychology, there's also this movement from the traditional psychological approaches that basically speak about something is not going well, something is wrong, and you're trying to reduce the symptoms and prevent it from getting worse. So basically, something is going wrong, and you're making it normal again. Very important. I'm not saying that one is more important than the other. But there's also a newer tradition on positive psychology, and that means you're already doing quite well, but you can still improve. You can improve your well-being, you can flourish, you can strengthen your character and build even more resilience. And they kind of like go hand in hand, and the techniques that we're using in psychology may be quite similar actually in both traditions. But it's really a bit of a mindset and a change in thinking about health and also our mental health. I did put one slide with some Sjögren information. Only one slide because I think that these 2 points are important, or actually the 3 points that are listed here are important. First of all, we're not talking about quality of life here because it's not important in people's life and people with primary Sjögren's life. We actually see that people with primary Sjögren have significantly decreased health-related quality of life. And it's actually similar if you compare on the different aspects of quality of life to other chronic inflammatory diseases such as rheumatoid arthritis or lupus. The prevalence, if we talk about mental illness, the prevalence of depression and anxiety are approximately 3 times higher in people with Sjögren's than in the general population. So this is a really important topic to keep in mind in our research programs, but also in our care for people with Sjögren's. Actually, I found this nice quote, and I put it here, is that because this quality of life is diminished, it suggests that targeted interventions should be carried out to improve health-related quality of life. I agree, but it's very hard to do that in a rare disease. And future well-designed and well-conducted studies with larger sample sizes may be required. I also agree, but again, it's really hard to do that in a rare disease. So I also start thinking about what can we learn from what is already available in terms of interventions, rather than wait for 10, 20 years to things to be developed. Because in my opinion, if you think about mental health care tools, you can start with tools that basically are available to anyone in the general public. Mindfulness-based stress reduction, for instance. Then, on top of that, there are challenges that you have to deal with if you are coping with a chronic disease. Any chronic disease. Can be diabetes, can be Sjögren, can be scleroderma, rheumatoid arthritis. Then on top of that, there's the challenges of living with a rare disease, like Sjögren's or scleroderma. And then on top of that are disease-specific issues that may be targeted. If you start with the top, and I'm not saying that that isn't a good approach, you're actually a long way out of making tools available for people with Sjögren's. I'm very dedicated to building that and to building that framework and to see where there's adaptations necessary, but also think that we shouldn't wait for so many years to give you some tools and some examples of what you can do to improve mental health. So that is the next part of my presentation, and the exercise is coming up. So just a reminder. So, tips and resources. Lifestyle. I actually put quite some slides on lifestyle, and then I saw that tomorrow there's a colleague of mine who's going to speak a lot about lifestyle medicine. Adopt a healthy lifestyle. May sound like an open door, but actually exercising, moving more, sitting less is very good for not only our physical health, but also for our mental health. Even a small, brisk walk, every movement counts. Peer support. And I think just by being here together and all of your organizations, you're taking very good care of that part already. It's helping for emotional support, informational support, like letting people know and navigating the health system, as well as tangible support. Just practically, you can help each other out. Talk with your healthcare provider about mental health. There are some tips in this link that I put here, but also the Dutch have a very nice conversation card that you can actually download and bring to your healthcare appointment and find information and support from trustworthy sources. So these are very generic tips that you could use. Okay, so now for this small exercise. And I already said that this is an exercise from the positive psychology to make you feel how a different outlook on your condition may affect your mental health and your view on daily life. So I would like to ask you if whether you have Sjögren's, another condition, or if you don't have any condition, think about any problem that may interfere with your life. So rate yourself on a 0 to 10 scale. You have a very nice notepad, you can write it down or you can just remember it. Where 0 is my condition totally controls my life and makes it impossible for me to live my life at all in the way that I want to. And 10 is very positive. I can live my life the way I want to, and my condition does not affect that. So take a moment to think about it. Where on this scale would you be? Good? Got it? Yeah? Okay. So now the next step is to think about why is it the grade that you chose and why is it not a 10? unless someone had a 10. But so why is it the grade that you chose, and why is it not a 10? Ready? Yeah. Why is the grade that you chose and not a 0? Got it? Okay. So here is actually a bit of time for discussion. I'm doing well for time, right? So let's take 2 minutes to discuss the difference in experience with your neighbor. So the difference between comparing the number with a 0 and comparing the number with a 10. So 2 minutes to discuss, and then I would like to hear back what you found out. All right. Let's move on. There are a lot of there are a lot of nice discussions. Are you done? Yeah, yeah. So thanks for all the nice discussions. Also in the back, can we? Yes, yeah. Okay, so I'm actually interested to hear some of your experiences. Is there anyone who would like to tell me, like, how does it make you feel? How was it to do this exercise? Yes? Thank you.
It's difficult.
Yes.
It's difficult, first of all, to understand the meaning, and you need to be honest with yourself to understand how the others react and how the others affect your feelings. We were discussing with the girls here, and we say that it's hard for the others to understand how the patients with Sjögren disease feel, because we have to put some limits on our daily lives, and the others cannot understand, even though as much as they want to understand you, they can't. Even our partners who live with us in a daily basis and at night, and they feel and they understand how we feel and how hard we try sometimes to go through the day. Even though our partners, there are times that they can't. A lot of people think or feel that we exaggerate on our feelings, or maybe we are bored to do something, or we are not interested, and they don't understand that it's our limits for the day. We can't go through more than we do, because if we do, we will have consequences.
Yeah, thank you. Thank you for sharing that. So it's also very important, and I think you pointed it out, to communicate with the people around us and to help them understand what you're going through. Yeah, thank you. Were there any insights from this exercise that someone would like to share? How is it to compare it with a 0 versus a 10 where you are right now? Yeah?
I felt like when I compared myself to a 0, I was thinking of all the things that are positive and that I am capable of doing, that get me to the number I felt I was at. Versus when comparing myself to a 10, I'm thinking about what are all the things I can't do. So thinking more negatively about, how it impacts me in a negative way. So one was more positive, I felt, than the other.
Thank you. Thanks. With 3 minutes? Okay. I have. I'm doing well for time. Were there any other experiences, or is it like general agreement? I can just leave this here because otherwise I look like I'm singing a song, which I am not. I will not bother you with that. Yeah. So on the one side, if you look at the 0, it makes you feel quite positive, but all the things that you can do, and the 10 about the things that you struggle with of doing. Or what we say in like more positive psychology: focus on the flowers, not on the weeds that are in your garden. But then, like, it's easier said than done, right? So how do you actually do that? First, by hopefully remembering this exercise and sometimes looking at what the 0 would be. But also, how do you take steps? What if your initial number was, for instance, a 4, or the number of your peer was a 4, and you would actually like to improve and move towards that 10? How would you do that? It's actually a first step to think about, like, if I would move from a 4 to a 4.5, and think about, like, that's a really small step, which also makes it more attainable. What would I need to change in my behavior? What would I need to change in my feelings? And what would I need to change in my thoughts? So how can I go from a 4 to a 4.5? And it's a very difficult question, and I know that I'm challenging you with these questions, but it also helps you make the step from a 4 to a 4.5 and the changes that you would like to make in your life towards a more positive mental health, very concrete and actionable. So things that you can actually do, small things that you can do in the next week or the weeks after to improve your mental health, going from a 4 to a 4.5, maybe to a 5 to a 5.5, etc. Also think about, like, what it means for yourself, but also what it means for your surroundings. So it's not just you, but also your family, partners, etc. Another thing that you could do to think about, like, how can I move up on that scale, if you would want to, is like the miracle question. And a miracle question basically is, if your problem would not exist anymore, what would your life look like? So what would you do? How would you feel? What would you think? So that is your 10, maybe. And what actions can you take yourself or with support of others to help go up half that point or 1 point? So small steps moving from where you were towards the 10, looking at what you can still do, so why it's not a 0, but also what you would like to attain. And this is actually a very classical exercise that is helpful for those who are in, like, the orange zone with, like, some mental health issues, but also in the green zone. Because in the green zone doesn't mean that you're necessarily at the 10. There may be room to grow and to flourish and to improve your well-being. Then there's some tips and resources for mental health issues, for if you're in the red. And I think it's really important to mention that there's disease-specific, but also many generic programs and interventions that could be available in your local setting, such as mindfulness-based stress reduction that you could follow. They may not be specific to Sjögren's, but in my experience, people, like, who give trainings are very open to adapting, if needed, to your personal needs. That's not only for people with Sjögren, but there's many other people who have, like, back problems or other reasons they cannot follow the classic traditional program. So be open to speak about that. there's things you could do in terms of relaxation, guided breathing, guided imagery, and I've put 2 links up here, and the slides will be shared. I know that you can look at. And get a referral to a mental health professional if needed. Don't walk around with your problems for too long. Ask for help. Try to accept that sometimes you're in the red, you want to go back to the orange or the green, and you may need a bit of help to get there. So thank you very much for participating, and I hope that this gave you some insight in what psychology could mean and contribute to improving quality of life. And thank you again for the organization for having me.
Thank you, Linda. Are there any questions? No questions? Okay, thank you very much. It was so nice to see how everyone participated and talked about the issues. Thank you for that.
Yeah, thanks.
Okay. So the next speaker, I'm very proud of him being here, is Wan Fang. He is professor of rheumatology in Newcastle University in the UK, and he is a member of our medical board. He's talking about fatigue this afternoon. Thank you very much for being here.
Well, thank you very much, and it was a pleasure for me to be in Athens with you guys today. And so it has been, this is something that we talk about patient's perspective. I can tell you this is how patient changed my perspective. When I first started being a consultant in rheumatology and looking at Sjögren, I did a PhD in immunology. I was thinking about, I'm going to be a laboratory scientist, going to be winning Nobel Prize. No, not never. But actually, once I actually met all my patients, everyone was telling me about fatigue. So my research has changed into doing fatigue. So, this is really the power of our patient. Anyway, so I'm waffling on, so I'm now going to move on to my presentation. So these are the conflict of interest. And so today I was just going to say in the next 20, 25 minutes, I'm going to talk to you about 4 points. So firstly, about fatigue being an important unmet need. And then secondly, we touch on about the possible causes or contributing factor of fatigue in Sjögren. And then we briefly touch on a possible way of managing fatigue. And finally, because the topic for this first conference is about today and tomorrow, so I want to talk about something about challenges, but also potential new approaches that we may be able to assess and monitoring fatigue in Sjögren. Okay, so many of you would know that, we all talk about Sjögren. The first thing people thinking about is dry eye and dry mouth. That was what I was told when I was in medical school. And then, of course, I was introduced to the concept about lymphoma. So this is the most important problem we need to solve. So, and then, of course, we learn about the systemic or extraglandular manifestation. This has always been a topic for the last few years. But day-to-day clinical practice, I have to say, this is what people keep telling me about, that doctors, can you not help me about my fatigue? So now, I'm not saying that any of the other clinical features are not important, but this is certainly one of the areas that I don't think we get an answer, and we need a lot more research into it. So why is this important? Because first of all, it is very common. So between 55 to 70% of the patient will report a significant level of fatigue. Now, you can use different scale. We'll talk about defining fatigue later on. But also, from a patient perspective, really, fatigue is the top priority. They think that they're in need of improvement. This is what they're really limiting their day-to-day life. We have a lot of data showing that it's really the most important factor associated with poor health-related quality of life. And we know that it also has substantial both direct and indirect health cost. Now, although the data from the US in 2007, although this is not specific for Sjögren, you can see that it's estimated more than 100 billion of excess annual direct and indirect costs is due to fatigue in general. So this is not really a problem just for the patient, but also for the healthcare provider, but also for the society as well. Now, this is also quite an interesting survey that came out from using social media posts. I thought it was actually coming from the lady sitting next to me, but I realized it's not. But anyway, so I'm going to talk about some of those. So these are some of the data that people analyzing the social media posts. Nearly 27,000 social media posts from US, Canada, Australia, UK, France, Germany, Italy, Spain, and in China. They are using AI approach to analyze the commonness and bothersomness. So you can see in here, what they actually find is that you can see fatigue, it is in here, that both they are very common but also extremely impactful from the patient perspective. What is also quite interesting is that when, from a patient perspective, what they talk about flare, I know that tomorrow you have a workshop talking about it. One of the symptom, cognitive fatigue and fatigue, are more strongly associated with what patient associated with a disease flare. So, and also we know that both fatigue, energy, and sleep and dry mouth are the most associated with activity constraint, with association score of 1, basically almost like a perfect association with those. So which I think is highlighting how important fatigue being a symptom from a patient perspective. Now also, fatigue is not just about for the patient, I already mentioned. There are a number of reasons why it's important for healthcare provider and society, because fatigue in general is also associated with many adverse health outcomes. There is a paper coming out in the last 2 years. So overall, the odds ratio, which means the improve in likelihood, so all adverse outcome is about 1.3 to 3.1 higher, fold higher, and even the increased risk is more than 2 times as higher, that they are more likely to die in somebody who got fatigue compared to those without fatigue. And all the other figures you can see are listed in here. Another thing is about disability in activity of daily living. The overall risk is almost like 4 times higher in people who got fatigue compared to those without fatigue. Now, so the next point that I want to briefly address is what actually causing fatigue. Now, of course, this is going to be extremely challenging. I'm not going to give you any answer to it, but I just wanting to highlight something that we've been thinking about. But before we answer that question, so I'm going back into our own observation in clinic. So what are some of the things that we know about fatigue in terms of what happened in patient with Sjögren telling us? So first of all, we know that not every patient with Sjögren have fatigue. I have some patients who are living almost like a perfect life. They don't really have any fatigue at all. Now, we also know that fatigue generally correlates poorly. Now, it doesn't mean that there's no relationship. It's just that these relationships are not very good. So sometimes it correlates with disease activity, but sometimes it doesn't. So the data are just very inconsistent, or at least the association is quite weak, which means that there may be some other factors involved. Now, at the moment, as far as we know, we don't have very good data, but overall the natural history, i.e. over time, what people's fatigue tends to be like, it's not like if you have longer the disease, you get more fatigue. Not necessarily the case, isn't it? So you may have fatigue all the way along. In fact, we have some data to suggest fatigue may even be improving over time. Now, whether it's because patient actually coping better or because they no longer need to go to work, they can retire, they can take their time. So there's no real correlation, strong correlation about the natural history, about disease progression and fatigue. Now, we also know that fatigue, although again not always, it's not just happening on its own. So often patients also have other symptoms such as pain and sometimes low mood. Now, we don't know whether it is the cause or just they cluster together or they are the consequence. Now, we also know that the response to currently available therapy tends to be very inconsistent. So some people seem to respond, some people don't respond. Now, but having said that, of course, I know that some of your colleagues here who've got some promising early phase trial data showing you able to improve some symptoms. So again, which means that we are obviously very interested in hearing more and looking into that further. Now, so what kind of inference or what kind of conclusion I can draw from all this observation is, first of all, assuming Sjögren, the central pathology, is due to inflammation and immune dysregulation, which I think there's quite strong evidence the disease is driving from that. What we could say is that the inflammation and immune dysregulation are likely to contribute to the pathogenesis, i.e. causing fatigue. However, inflammation or immune dysregulation on their own is neither sufficient, because if they're sufficient, then every single patient with Sjögren should have fatigue, which is not the case, nor necessary, because we know that sometimes even if you treat all those immune pathology, fatigue can still exist. So therefore, there is something else that's going on. So therefore, the other conclusion we can draw from this observation is that there are likely to be additional mechanisms involved in the causes of fatigue. And then of the disease. And then the final question actually didn't show up quite well on the slide. I think it's maybe the lighting. There's a very, very grey faint point in here, is that there may well be some different type of fatigue as well, which we need to think about. Okay, so what do I think about the overall pathophysiological model of fatigue. So first of all, we think about a person. So we know that in Sjögren, which is due to immune dysregulation. So I would say that any kind of inflammation or immune insult to the body would be, of course, causing various autoimmune conditions, including Sjögren. And those inflammation can cause pain, fatigue, and depression. But of course, this is in the acute setting. But whereas what happened is that in a setting where things become chronic, which is like in Sjögren, that the inflammation are continually unabated, then the body are likely to develop some kind of immune regulatory or other adaptive mechanism going to come into place to try to restore the changes in the immune system. And I think those kind of immune regulatory mechanisms can also contribute to fatigue and also can contribute to other changes in mood or other symptoms such as pain. And often, I think in some individual, potentially, where those immune regulatory or other adaptive mechanisms become defective, then what happens is that they have their own perpetuation cycle of fatigue, pain, and depression without actually relatively minimal contribution from the inflammation itself. So the next question is, what are those potentially additional mechanisms that could be involved? So a lot of different candidates has been being proposed, so I'm not going to go through every single one of them. So, people talking about, neural, metabolism, the CNS changes, talking about the autonomic system, the hypothalamic, pituitary, adrenal gland axes. We're talking about circadian rhythm, sleep, depression, anxiety, pain, but also some of the metabolic pathway, cardiovascular, respiratory fitnesses. And all these things, I think, are likely to be potentially either related to inflammation on its own, but also they can all contribute to fatigue, and they all, I think, are related to each other. So that's why it's making it so difficult to actually understand fatigue, because there are so many complex interacting mechanisms at play. Now, so the other thing is thinking about different stages of fatigue. Well, in my view, I think inflammation probably play a much bigger role in the initiation of fatigue. But actually going on when the disease is being established, I think that other factors such as the genetic or environmental factor, that including previous illnesses, trauma, etc., those things can also contribute to fatigue. And particularly, I think they may play more a significant role in the maintenance of fatigue. And whereas when there's this disease flare up and when there's extra inflammation, then the inflammation may play, again, a more prominent role. But these are just my hypotheses, by the way. Now, so based on all this current understanding, albeit incomplete, I mean, just like the lady just said, we got a problem, but we need to start dealing with it. So even though we don't have a complete picture about what causes fatigue, we need to use the information that we have now to try to manage fatigue as much as we can. So one way that currently, how I approach it in my own clinical practice would be try to, as best as I can, to actually using the framework that I just talked about, the various contributing factors of fatigue that we know about, and to think about what are those factors. Could they apply to the patient sitting in front of me? And then I could think about, well, is that because there's a lot of information going on? Then I'll be thinking about, of course, treating the information with whatever tools that we have available. If there's a lot of mood problem or pain, we can think about different way of approaching this. I'm not going to go through all the different list. And then if there's problem with sleep or circadian rhythm problem, we can address that using various different approaches. And similarly, if we're thinking about, if there are problem in terms of metabolic or cardiovascular respiratory changes, we can think about way to approach it. If they're thinking about a CNS neurotransmitter pathway, there are ways that we can think about that. And similarly, we can think about the XPA axis and also the autonomic dysfunction. So I wanted to mention about, again, thinking about today and tomorrow, I want to mention a couple of new treatments that are being published recently. Now, of course, I know that there are more recent data as well. You'll see some of the abstract in EULAR, and there will be abstract coming up in ACR. But I'm just talking about one of the therapy that I'm involved in the phase 2 clinical trial, which is called RSLV132. In this particular treatment, which is targeting the RNA fusion protein, targeting the initiation of the interferon response. So in this small phase 2 study, in fact, we can see that this particular treatment able to improve mental fatigue significantly. But also we can find some objective improvement because these people are able to perform a neuropsychological test called digital substitution, symbol substitution test, you can see that those people who are actually taking the active treatment able to do this test much quicker than those people who are actually only taking placebo response. And similarly, we run a SAM-controlled clinical study looking at non-invasive vagus nerve stimulation. Again, we can see that those people randomized to receiving an active device, they can actually have a significant improvement in their physical fatigue score, whereas those actually randomized to a sham vagus nerve stimulation device, there's no change in the physical fatigue score, which again has been recently published as well. Now, so in the final section, I'm just going to also mention a little bit about how do we measure and also monitoring fatigue, because that often is a very difficult communication in a clinic setting. People were telling us they're fatigued, but actually, how do we know are the fatigue actually improving or getting worse? Because without that kind of tools, we can't really try to assess any treatment response, isn't it? Without an accurate and reliable tool to assess fatigue, we can't really work out whether any treatment are actually effective or not. Now, let's come on to some of the things that we need to think about. Now, although we talk about all this fatigue problem, but actually, I can tell you, as far as I know, there is still no agreed definition of what fatigue is. So which means that what you talk about fatigue and what I talk about fatigue may well be not exactly the same. We may be very likely talking about similar phenomenon, but we don't necessarily say that we're exactly the same. Now, one thing that I know, well, I hope that the people sitting in here would agree with me, I think the fatigue experience by patient with Sjögren is not the same, qualitatively, it's not the same as fatigue you experience by otherwise healthy individual, before they become ill. So some of the key features, I would say, from listening to our patient is that they're generally more unpredictable. They can't tell why they suddenly get so fatigued. They can be very variable, and they can be very profound, which means this fatigue is not you can just shake it off. People were telling me that they will have to stop the car while driving and rest for half an hour before they can continue on the journey. And also another thing is they don't improve with rest. If I go and tell my patient, go and have a good nice sleep, they're going to slap me in the face. They will tell, well, actually it doesn't work. Don't tell me that. I know how to rest. Now, but however, in research, and often what we do is that actually fatigue is often defined by a particular questionnaire that we use. But even if we are using the same questionnaire, there is no agreed cutoff value, and they can be very, very variable between what is fatigue and not fatigue. So i.e. there's still a lot of improvement we need to make in terms of getting to a grip of how we can do fatigue research and measuring fatigue. And then the next question I think is important to think about is, are there any different type of fatigue? Now, I think this is still debatable, because we know that fatigue is often very common, not just in Sjögren, but also actually many other rheumatic and also non-rheumatic diseases. And also then the question is the fatigue in Sjögren different from fatigue, let's say, in rheumatoid arthritis? My sense is that probably not. And then the other thing is thinking about, do we really think that mental fatigue or physical fatigue, or some people use the term central fatigue, peripheral fatigue, are they really completely different phenomenon? Or are they actually the same phenomenon, but you have a different dimension or different facet? And again, my own view is that I think they are the same phenomenon, but with different facet, because I don't often come across patients who only tell me you just have physical fatigue and the mental fatigue is completely normal, no fatigue at all, or the other way around. So it's very uncommon, I think. So I suspect it's probably the same phenomenon with different facets, but of course I could be wrong. So the way that at the moment, we published a review article in Nature Review Rheumatology a few years ago. So the way that at the moment, at least from my research agenda, I'm currently defining fatigue as a multidimensional phenomenon in which there are physiological, cognitive, motivational, and emotional state of the body are being affected, resulting in impairment of the individual ability to function in their normal capacity. So probably going back into some of the question about asking, what would be your scale 1 to 10, what can you do, what can you not do, kind of question, really. So therefore, if we're thinking about that then what are the challenges? So firstly, I think because if you're talking about fatigue being multidimensional, so we need to think about making sure we're covering all the different aspects. And then fatigue, of course, are we measuring about how severe they are or how they impact on people's life? Because that may not necessarily be the same. And do we have a measurement that can capture all the variability? And then if we are thinking about it, they're so variable, how do we capture it? Do we going to ask them how they feel at that time? Or are they trying to ask them how they average over a period of time? And then what is a reasonable average period then? And of course, we need to think about the confounders, because I talk about fatigue often, come with many other symptoms. And then it's about how do we place the importance about subjective response, or how do we observe or some kind of objective measurement of fatigue. Now, so I'm going to illustrate some of those potential problems with the current questionnaire-based assessment. So let's say in the fatigue severity questionnaire, which is often being used, but you can see in this actually questionnaire, there's actually very little question to talk about different dimensionality of the fatigue. So for example, mental fatigue is not really properly assessed in this questionnaire. And then in here, talking about in the past week, but of course, is the past week is the right approach, or should we be thinking about shorter or longer period? And then thinking about the severity or impact in here, talking about the fatigue among the most disabling symptom, interfere with social life. So, you know, this is to think about what kind of confounder it could be, because we know that if people who got depression, it will affect those who score quite severely. And then finally, if you think about question 2 and 3, could we potentially, instead of asking the patient to report on a score, they may be able to assess using a more objective measurement of that. So one of the potential novel approaches you can think of is that in here, in the fatigue impact scale, am I running out of time? Yeah, okay. So I'll quickly use that. So basically, you can think about there may be objective way of, you know, assessing some of these symptoms, and similarly, some of the neuropsychological tests can be potentially useful. And then we have done some early studies showing that based on some activity and also ECG measurement, we can actually find some, using AI approach, we can address some of those, potentially find some solution to measuring fatigue. And we are now doing an IMI project looking at this called IdeaFast, which is currently running the study with over 2,000 patients that we're recruiting to. And so that is basically what I'm going to say. I think I can skip the conclusion slide, really, and I think I already talked about those already. So sorry, I'm running out of time. And I'm just going to thank you all the teams and people who are supporting me. Thank you.
Thank you so much, and sorry that I...
No, sorry, I just talked too much. Stop me, you know.
Are there any questions?
Hi.
Fine, thank you. It's not really a question, but just to comment, because many years ago, maybe you remember, we performed a rituximab study. So it was negative for the primary endpoint, but it improved the fatigue. So, and statistically, so I think there is something, immunity, inflammation, something, and we improve the patient with this. Well, of course, it's not sufficient to use this treatment for that, but that means that blocking immunity do something.
Yeah, and I'm sure you're aware of the, you know, the presentation at EULAR from some of the other, you know, clinical, drug in development. There's some improvement as well. I think the whole point is that I think there are other things. So information may treat certain degree, or maybe it's treating certain group of people, but whereas other people may or may not be improving. So it's about identifying the right target as well, I think. Yeah. Okay, thank you.
There's another question, sorry.
It's not a question, it's just a common as a patient that I'm living with fatigue. Okay, so you as clinicians, you have to have in mind that patient having fatigue, when they are having some other treatments also, they are becoming better. I mean, when they have physical activity, their fatigue is becoming better. And when we are better on our mental health, the fatigue, again, is better. So it's not only with treatments or with disease issues, but it's also changing our lifestyle. Will improve the fatigue.
I fully agree with that. Yeah, thank you for sharing.
Are there more questions? No questions? Thank you very much for your talk. So now we were supposed to have a talk from Gemma McCready, but unfortunately, I'm getting tired, I think, a bit. She isn't here. So we tried to have her on our next conference, but we have to wait 2 years. But in the meantime, we just follow the program with our next speaker. And that's Eleftherios Bournousousi. And his talk is about the significance of physiotherapy and the quality of life of patients with Sjögren's. The floor is yours.
Thank you. I have this one. Okay. Hello, everybody. I'm really glad to be here with you. I am a physiotherapist. I am the vice president of the physiotherapists here in Greece, of our national organization. It's a regulatory body. When you have to work as a physiotherapist, you have to be a member of our national organization. And I'm going to speak to you about physiotherapy and the quality of life of patients with Sjögren. I want to thank Kati Adonopoulou for inviting me and all of you for being here in Greece. I thought we have a great weather, and I think that you will enjoy your stay here in Athens. First of all, I wanted to say a small definition about Sjögren. You know that Sjögren symptoms are more than that primarily affects glands that produce saliva and tears, leading to symptoms such as dry mouth and dry eyes. But it's not only this. We have more problems with Sjögren syndrome, and I think that is underdiagnosed. We have more people with Sjögren, and this is something we are facing in our clinical practice. Many times we have people that they think that they have mechanical problems, and when they speak us for their dry eyes or the problems they have, we suggest them to go to a rheumatologist to make a bigger research about their medical condition, and we are getting more people that are diagnosed with Sjögren disease. We have the primary and the secondary Sjögren syndrome. I have read that we have more than 1.3 million Americans are affected now with Sjögren, and I think that there are more than 1 million. We know that more of them are women, and that they are 40 to 50 years old. We have common symptoms on Sjögren. The most important is pain and fatigue. We have emotional well-being. We have social and work-life problems. We have treatment side effects, oral and dental health problems from Sjögren disease. Pain and fatigue, we will speak more about that because I will explain to you how physiotherapy can help us. Emotional well-being is because many people don't know the physical history and what will happen to them with Sjögren disease, and this is cause problems. And you have to pay many things for treatments besides the drug treatments, and this is you have to go to many doctors, you have to make many exams, and you have to pay more. And most of the time is out of pocket, these payments. This cause problems, stress, and some things, and problems with your work because you have problems to work efficiently. The secondary Sjögren is a form of syndrome which develops after the presentation of primary disease, and we have many times Sjögren with rheumatoid arthritis. I have many people with rheumatoid arthritis. It's okay. Thank you. Thank you. the treatment that we have is, you know about that, tears, artificial saliva, nasal sprays, many things that can help you, and many drugs, new drugs that we are taking to help you. But I will stay only about the physiotherapy treatment. There are published guidelines. The first of all is the Casson's guidelines. It was the first that said that physiotherapy can help you with Sjögren syndrome because it can help you with exercise therapy. And the second we had was the questions was 2017. They have published the treatment guidance for rheumatological patients. And they describe it as physiotherapists that they have a great role on fatigue management. The second, it's an open access. You can easily find these guidelines. It's the British Society of Rheumatology. They told it's a new guideline that says that physiotherapy can help you to overcome obstacles that you have, like edema, like pain. And the third one, guidelines that I want to show you, it's the clinical practical guidelines that the physiotherapist has, and this is an open access too. It's clinical practical guidelines from the Physical Therapy Association in USA. They had studied many patients. They have made many clinical trials to see how physiotherapy can help you and when it can help you. They had, after many studies, they say that there are three groups of patients, that three types of management of people with Sjögren. The first is to give them only clinical advice, to tell him what is better to change in their life, to be more active, to get up. I want you to make a small pause for just 30 seconds. I want all of you to get up. We are sitting too much time, and it's important to move, to stretch our hand, okay? Take care of the people next to you, okay? No, we don't go. Just make some movements, because when we are sitting for so long, we have a fog. It's difficult. And when we give advice for ergonomy, we say that the best posture where you are sitting is the next sitting. You don't have to stay in the same position for too long. Okay, you can sit now, and we can continue. Huh? Okay, εντάξει, now get up for a photo. All of you for a photo, thank you. I am continuing with APTA clinical guidelines. They have three groups. The one is that they just give advice to people with Sjögren. The second is to give advice and exercise, but prescribed exercise, customized to every person, not a general exercise. And the third, when something is more complex, to have education, physiotherapy, and exercise, prescribed exercise, when we have more symptoms. They had many questions about if we have to use modalities, physiotherapy modalities like cold, hot, TENS, ultrasound therapy, and they decided that we shouldn't have such modalities. No modality can help you with Sjögren. We cannot do only ultrasound and wait that something will change to you. We can use ultrasound only when you have a pain, when you have a stiff joint for 1 or 2 days to help you to cope better with exercise, not as a monotherapy to have ultrasound or laser or TENS. This can help you not only if you have it in a plan, in an exercise plan. We have it as a help, a little help when you have problems or you have pain. And this was a great change because many people thought that only these modalities could help people with rheumatological disease. And this is not only for America, the only passive mobilization, and as a second help is massage, thermotherapy, medical taping, dry needling, just to help someone to be more active. Okay? The physical therapy management, what we can help you in our clinical daytime. We can make management of joint pain and fatigue. The joint pain, we can make mobilization. We can use some modalities, or we can advise of which exercises you have to do or you don't have to do, and to make a program to help you. Posture and ergonomics is the second fact when you have problems with Sjögren, how you can sit, what changes you have to make at your house to be easily or to your work to have an easier day. When you have breathing and chest problems, how breathing physiotherapy can help you with teaching about techniques, breathing techniques, oral and facial exercises to help you move the muscle. Fatigue management is a very big issue, and I will show you many new articles that physiotherapy can help you in fatigue management. Exercise programs, pain management, patient education, that, like we said previously with the APTA guidelines, support and motivation. The first article, it's an old one, it's from 2007. It's the first time that I found that a moderate to high intensity level of exercise can help people with Sjögren. But they said that we have to make more and more, to search it more to see how it can help and measure the help that we get from physical therapy management. We have more clinical trials about physiotherapy. The effects of physiotherapy was from resistant training, and when you have a physiotherapy, we have made 60 women who were participating there in 2 groups, and we have comparisons between the 2 groups about VO2 max and the changes they had, and the changes that they have at SF36 questionnaire, and we found that it's a great changes when you make physiotherapy. All this, you can find it in Pedro. Pedro is a database for physiotherapists. It's open access for everybody. You can type pedro.com and you can see all these RCTs about physiotherapy and the help that they can give you. Cardiovascular effect of physical exercise in primary Sjögren syndrome was another. The conclusion that we are getting is that it helps. It's a significant help when you make cardiovascular exercise. They had 2 groups with women, and there is a great change when you have supervised exercise. It's not the same that they have groups with people that make exercise, or they have their usual life, or they have supervised exercise with physiotherapy. And they have, it's the first that I saw that they have checked if exercise can cause problems. they are sure that exercise won't cause any problem to people with Sjögren, because some people said, if I have a Sjögren, I have pain, exercise could help me or could make it worse. And we are sure that exercise can help you and won't cause any problem. And the resistance exercise training, it's a new, that you can see, a new trial. They have more than 50 women in the 2 groups, and they are improved in cardiorespiratory fitness. Every year we get 5 to 10 new RCTs about how physiotherapy and how exercise can help Sjögren. That's why the thing that you have to take at home is that exercise helps. When you don't have big problems by yourself, by changing your life, by participating in sports or in dancing or everything you want to do. But when you have bigger problems, you have to ask the help of your physiotherapy to help you. We had one RCT about how physiotherapy, acupuncture can help you. It was the only one that didn't give a significant increase between the 2 groups. And I think we have to make more RCTs about acupuncture. Exercise is the one that is sure. And the previous one, the previous one shows that you can, with physiotherapy, you can make electrotherapy and help with electrotherapy to produce saliva and have a better oral health. But it's a small RCT, it's not many people participating. Physiotherapists, in Greece we are 10,000 physiotherapists. There are many physiotherapists all over the world. Our organization is World Physiotherapy, and we have every year at 8 September the Day of Physiotherapy. The last 2 years was for arthritis and for rheumatoid arthritis. Many physiotherapists are getting information about rheumatological, autoimmune problems, how to understand, how to see, and how to help people with such a disease. Thank you very much for having me here with you. If you have any questions.
Are there any questions? Yes. Katie. Katie is waving.
One question and one comment. Can you be able in the next years to have specific exercises, physiotherapy for Sjögren's patients?
Yeah,
Not for rheumatological.
No, we don't have a special for Sjögren because every person is different. When you have another lady, you make other exercises. You have to test them and see. He has respiratory problems. He has aching joints. It's different problems. Every person is different. That's why we use the clinical guidelines from rheumatological patients, because we don't have the same exercise for everybody. The general advice is that WHO says 150 minutes of movement and to lift weights and to make exercise is something that you have to have it every day. Okay, it's important every week. Every week it's 150 minutes. You have to work with this.
Okay, thank you. And one question: Can you give us and show to us some exercise right now with some music, just to be much
Yes.
Okay.
Okay. The best exercises is to work with big muscular groups. This is important, not to have problems with the joints and your spinal cord. It's to get up 10 times. I think it's okay for everybody. To get up from your seat 10 times. Yes, and sit down. Okay. Okay. Ναι, τους λέω να σηκωθούν 10 φορές. Up on your toes, okay?
Don't do that, don't do that.
Yes, 10 times. 10 times. This is good for stability and for big muscular groups. It's the second exercise that you can do safely.
Those exercises are not just for the patients.
For all of us. For all of us.
Got one question. Every single patient knows that
Let them listen. Physical activity is good for everybody, but for people with Sjögren or other autoimmune disease, it's obligated to do these exercises. You have to write and say, I made 30 minutes, I had to make 40, I have 10 minutes more to do the next day. You have to be in a program. This will change you because we forgot. We say, okay, I will do it next day, and we cannot keep a program. And to work with friends, okay? With friends or people with organization like this you have, to get together in a group, make exercises, and it will be a better commitment to the exercise.
Yeah,
Okay.
exactly.
But you will be together later.
That was my comment. I think that every single Sjögren patient knows that physical activity is important.
Yes.
But you know, when you can't measure what benefit it is for you, when you go to your physiotherapist and you come back, you're tired, you are in pain, in joints, in muscles and everything, you just want to quit because patients really don't understand the benefits. What message could you tell really precisely?
The first time that somebody goes to a physiotherapy has to make some test. To make a test, a small test like a 6-minute walking test, and see how many meters you can walk, or what you can do, how many times you can get up from a chair in 30 seconds. And you say, okay, for your age, you have to be 15 or 16 or 17. And he sees that in another month, when he makes the same exercises, and he had the 17, and now he's at 19. And he understands that he make a big change. We have protocols about to measure the ability of a person. We know we have standards about the age. We know that you are 40, you have to do this. When you are 50, you have to do that. And we can measure the changes, and this is clear for the patient to understand what he's going to gain with exercise.
Okay,
Thank
there was
you.
another question in the back of the room, but I don't see another hand. Yeah, yeah.
Do you recommend any type of specific breathing exercise for patients? I've heard, with a patient that has inflammation and pain,
Mark, I
they
don't.
have a lot of anxiety,
Yes.
a lot of stress, and it makes it harder for them to breathe. So do you have an exercise that you would recommend?
Yes, for people that have anxiety, the best is to swim. And swimming is one of the best. It's safe for them, and it's relaxing for people with anxiety. It's a safe exercise, and when they are their physiotherapists, they can make more strong exercises when they are working with him. Okay, but when he's alone, swimming and walking, if you have a walking and you know that you have to walk for 10 or 20 minutes, or if you have to make a certain distance, it's okay not just to walk without counting what you are doing.
Okay. And I have a remark. In our meetings in the Netherlands, we have, since we have Veronica as a president, she has told us every half an hour, we go up for 2 minutes.
You are the greatest country in ergonomics. I was in Holstebro, and I don't know if you have been in Holstebro.
No.
No, it's in Denmark. You said in Denmark?
No, the Netherlands.
Netherlands. No, I'm sorry. And Denmark and Netherlands are very good in ergonomics. It's the best advice to keep moving.
But and I want to add that I at the end of the meeting, I'm not so tired as before.
Yes.
It helps.
Yes, it helps. Sorry.
Another question there? Yeah.
Just a question. Is there a difference between short, high-intensity exercise and moderate to high, longer aerobic exercise in terms of training?
They suggest intense exercise for Sjögren.
Yeah, for fatigue, in terms of improving fatigue,
yes,
for instance?
Fatigue, they have found that intense exercise is better.
Okay, thanks.
Okay.
What
Yes.
exercises also if you don't want to swim?
You can make aerobics, exercise, walking. You can do anything you want. The message is exercise.
Okay.
Whatever you like. If you like dancing, dance. Okay.
Another question? No? Okay. Thank you very much.
Thank you.
And see you again. Yep. Now we have the next session, and that's a pre-recorded one. And that's from, I had to read it, Alessia Lumo, and she is a rheumatology consult, international medicine, and never, I can't pronounce it, but she told us more about the neurological problems by Sjögren, and I'm very curious about that. Okay, let's start it.
Thank you very much for the invitation, and please accept my apologies for not being in person with you today, but I could not travel due to other commitments. But I'm very happy to discuss with you the neurological aspects of Sjögren's. Since we know that Sjögren is a chronic, disabling systemic disease, and as such, it is characterized by a number of different extraglandular manifestations, of which neurological manifestations are an important part, and they can severely impact the quality of life of people living with this disease. But talking about the neurological manifestations of Sjögren's implies that we first discuss about the nervous system and try to understand better which are the parts of the nervous system that can be affected and how this translates into symptoms. So here you can see a very simple schematic representation of the central nervous system in pink and the peripheral nervous system in yellow. And within the central nervous system, the brain is the master that controls all the body's function. And from the lower part of the brain, we see a long bundle of nerve that runs through the spine and is protected by the spine, and is called the spinal cord. And from the brain and the spinal cord, we have a huge number of nerves that branch out to reach every part of the body. And there are three types of nerves: the cranial nerves from the upper part of brain and spinal cord, the spinal nerves branching throughout the spinal cord, and autonomic nerves. And you will see in a minute why it's important to know this difference. This is a very schematic representation of how a nerve look like. So you see the main body of the nerve that includes bundles of nervous fibers, and these are individual fibers. And this structure resembles that of a cable that we see in our daily life. And you know that even if cables may have different thickness and different diameter, then the inner structure is the same. So we can think about nerves as different cables sharing the inner structure, but having different diameter. Different part of the body, different diameter of the nerve based on the function they have to make. So we can imagine the nervous system like a network that brings messages from the brain to the body and from the body to the brain. And to do so, the nerves are needed. The cranial nerves are those that connect the sense organs of the head and neck to the brain, and so they bring information about smell, about sight, about hearing, and about taste. But cranial nerves are also responsible to mediate movements because they bring messages from the brain to the muscles of the head and neck for eye movement, for chewing, for swallowing, for facial mimic, and also to move the head and neck. Likewise, the spinal nerves connect the spinal cord with the body, and they can either bring information from the body to the brain about sensations, and this is the example of skin surface, where we can have pressure stimuli, pain stimuli, hot, touch, cold. And each of these goes back to the brain through the spinal nerves. But spinal nerves are also in charge of movements. Movements that we have to think about. So if I want to wave at you, my brain brings the information to the muscles of my hand through the spinal nerves. But if I want to walk, then the brain brings this information to the muscles of the leg. And why I'm saying specifically movement we have to think about, because for all the functions and movements we don't have to think about, then the autonomic nerves are in charge. Autonomic nerves, as you can see here, are two main branches. Each of them is linked with the same structure, but mediates opposite functions. And this is why the sympathetic autonomic nerves are those that prepare the body for stress. So, for instance, when we see something scary, we feel our heartbeat getting faster, we start sweating, we breathe more frequently, and this is the so-called fight or flight response. But when we are ready for rest, the same parts of our bodies are regulated by the parasympathetic nervous system, so the heartbeat is slower, we breathe less frequently, and also our digestive system is ready to do their work and digest and absorb the nutrients. And not only the type of nerve is important to remember, but also the caliber, the thickness, as I mentioned earlier, because there are small fibers that are very tiny nerves and very vulnerable nerves that bring information both within the peripheral nervous system and the autonomic system. So information, for instance, about temperature, about pain, about itch, but also about thermoregulation, gastrointestinal function, and other autonomic functions that you've seen before. So now that we know which are the parts of the nervous system, let's see which is the impact of the neurological manifestations of Sjögren's. So we know from the different studies from the scientific literature that neurological manifestations can occur in 18 to 45% of people with Sjögren's. But as a doctor, when I see broad ranges of percentages regarding symptoms, this automatically tells me that we don't know much about that specific problem, because some studies may underestimate the problem, some other studies may use different ways of assessing a specific symptom related to a manifestation. But what we know for sure is that the peripheral nervous system is the one most frequently affected, and that in the majority of cases, neurological manifestations occur together with other extraglandular manifestations. And looking at specific manifestations like those of the central nervous system, well, you see that the proportion of people affected is even more different, from 2.5 to 60%. And this reflects the fact that some studies record symptoms related to central nervous system manifestations, and some other studies record abnormalities seen on imaging, for instance, with the brain magnetic resonance imaging in patients without any symptom. And it's important to note that all the manifestations involving the central nervous system are rather non-specific for Sjögren's. We see stroke, we see trigeminal neuralgia, we see cognitive dysfunction. So it's not easy to attribute these manifestations to Sjögren's or to other diseases. And also the symptoms are very non-specific: headache, visual impairment, fever. So it's really complicated for central nervous system manifestations. But unfortunately, it's not easier for the peripheral nervous system manifestations. Here, the proportion of people affected ranges from 5 to 21%. But again, this may not be the real picture of the burden of these manifestations. But it's important to mention that peripheral nervous system manifestations can be the first symptom of Sjögren's in up to 1/4 of patients. This tells us an important thing, that we not only should raise awareness in the rheumatology community about neurological manifestations of Sjögren's, but also in other doctors like general practitioners, neurologists, emergency medicine doctors, so that neurological manifestations are also considered as possible manifestation of Sjögren's. And unfortunately, for the autonomic system manifestations, we know even less. We know they are burdensome, but we don't know the actual size of this, the magnitude of this problem. And in recent years, also specific autonomic syndromes like POTS have been linked to Sjögren, but again, we don't know the exact burden of this. So I've specified different types of nerves, different functions mediated by the nerves. But why it's important? It's important because based on which nerve and how many nerves are damaged, the clinical manifestations will be different. So if the damage occurs in a nerve that brings a sensation from the body to the brain, then the symptom will be an unusual sensation. For instance, I touch my hand, I do not feel touch, I feel pain. Or I do not feel anything at all, like if I have anesthesia. Or I may have balance problems, spontaneous burning feeling. But if the damage occurs in a nerve that brings the information from the brain to the muscle for movement, then the symptoms will be different. I may have muscle cramping, I may have abnormalities in the reflexes assessed upon physical examination, or twitching. And if the damage occurs in an autonomic nerve, then I may have problems in regulation of sweating, heat or cold tolerance, digestive problem, sexual problems, or orthostatic hypotension, that feeling of dizziness or even fainting when standing up. So when larger fibers, so larger nerves, are damaged in Sjögren syndrome, there are two main clinical pictures that can be observed. But be aware that being the most frequent does not mean being the only. So this is not so very easy in clinical practice. This is what happens when large fibers of extremities are involved and only fibers and nerves bringing sensations are damaged. So we have this distribution called the glove stocking distribution. There is an increased contact sensitivity, but there is a reduced perception of temperature, vibration, and the strength is not affected because there is only damage on nerves bringing sensations. But what may also happen is that both sensitive nerves and nerves responsible for movements are damaged, in which case we will have a more complex scenario with abnormal sensations, pain, burning, distribution that is very difficult to predict, and also muscle weakness. And when small fiber neuropathies are damaged, then we may have again a similar distribution, glove and stocking, or more broad distribution, but only for sensitive information, so only for perception of sensation. But we also have autonomic symptoms, because we said that small fibers bring both sensations to the brain via the peripheral nervous system, but also information through the autonomic system. So the way to the diagnosis of peripheral neuropathies, so of peripheral nervous system issues, is not easy at all. We start from symptoms, we record the symptoms, we perform a physical examination, but then we need to objectively assess the function of the nerves. And there is a huge range of different tests that can be performed, and unfortunately, this test may turn out negative, falsely negative. And for specific conditions like small fiber neuropathy, we may need an additional diagnostic test, that is the nerve biopsy. But not all hospitals perform nerve biopsies, so it may be difficult to access this further diagnostic procedure. And another important aspect to keep in mind is that not only Sjögren's can cause neurological manifestations. There are so many other possible coexisting conditions that could cause similar symptoms. And this table shows some example, with diabetes being the most known and frequent, but also vitamin deficiency or infections or other immunological diseases like celiac disease. So it's not easy to understand whether these symptoms can be attributed to Sjögren's or to another coexisting disease. And an additional layer of complexity is provided by the so-called mimickers. So clinical entities, diseases that mimic the symptoms of peripheral neuropathy but are not due to a peripheral neuropathy. For instance, fibromyalgia, that is so often associated with Sjögren's. So we may find ourselves in different situations. So we may have neurological manifestations of Sjögren's. We may have neurological manifestations due to Sjögren's, but also due to other coexisting diseases, such as diabetes. We may have neurological manifestations due to coexisting diseases, but not attributable to Sjögren's. We may have symptoms mimicking neurological manifestations of Sjögren's, like fibromyalgia. Or we may have neurological manifestations due to Sjögren's, due to other coexisting diseases, and on top of this, due to a mimicker. So it's very complicated to say which condition causes what, but this is crucial for the treatment, because we have treatment recommendations. Unfortunately, however, the treatment recommendations state that the use of immunosuppressive drugs, of corticosteroids, of biologic agents is mainly based on their efficacy in other autoimmune diseases like lupus and rheumatoid arthritis, but the data on Sjögren's are not solid and come from small studies. So we certainly use glucocorticoid, rituximab, methotrexate for central and peripheral nervous system manifestations, but they may not work as we would expect them to, because they have not been specifically tested in large studies in Sjögren's. And for the autonomic nervous system, unfortunately, the situation is worse, because we only have symptomatic drugs that we may use due to autonomic system diseases in other settings. But as a matter of fact, again, they may not work as we would like them to. So it becomes clear how important the non-pharmacological treatment is. And we can use oral supplements to restore good vitamin levels. We can use magnesium, that is a key mediator within the nervous system. We can use other compounds that have shown certain efficacy, for instance, in diabetic neuropathies. But it's extremely important that we recognize how helpful physiotherapy can be, and also cognitive behavioral therapy to strengthen the capability to cope with symptoms that unfortunately cannot be resolved by treatment. And we recognized and acknowledged how huge unmet needs we have in the setting of neurological manifestations of Sjögren, that we have set up a research team. You can see myself, you can see two colleagues from my team, Anna and Coralie from Sjögren Europe and Valentin from the Medical University of Vienna. We have co-designed the survey to explore the perspective of people living with neurological manifestations of Sjögren's. The survey was developed in English and translated into several languages. It's now available in French, Italian, Spanish, Portuguese, and German. And this is a QR code to access the survey, so feel free to spread it to anyone that may be interested. And the survey was launched about 1 month ago, and as of today we have over 800 responses, but we plan to keep it open until the end of the year. So if anyone would be happy to implement additional languages, feel free to reach out any of us in the team and we can discuss how to move this further. So in conclusion, neurological manifestations of Sjögren's are a major unmet need not only for people living with the symptoms, but also for us rheumatologists. And we need to raise awareness not only in the rheumatology community, but also in doctors from other specialties, like GPs and neurologists. And that unfortunately, we do not have strong evidence on pharmacological treatment. So the manifestations may not be successfully treated as would our expectation be. So non-pharmacological treatment should be considered as a support. And I would like to conclude with a slide that I always use when I talk about Sjögren's. And I like to think of us doctors up here on a hill looking at this land, and you see there is a sea of fog. Some parts are visible, many parts are not visible, but it is our duty to handle the fog and see the land in full to ultimately help people living with this disease to improve the quality of their life. And I thank you very much for your attention.
Thank you, Alessia. I have one question to you. How many people have neurological manifestations? 2, 4, 5. Okay, I was curious myself. Okay, thank you. And now there is another thing.
Just a quick comment about the survey Dr. Aluno told. You might probably have received already an email about that survey. I don't know if you've got it or not. As soon as the languages are done, we will, from Sjögren Europe, send you the link for the survey, because it's really, really important that you, patients, National Association of Patients, replies to disseminate the survey. The more patients will reply, the better the survey and the study will be. Okay, thank you so much.